Welcome everyone to this webinar on innovations through collaboration. And we're very delighted to highlight the work and achievements of our collaborative that almost many of us have been part of, the GlobalSurg as well as the COVIDSurg Collaborative, and representing the collaborative that actually in terms of surgical oncology had produced two remarkable studies, the GlobalSurg 3 study looking at various cancers, as well as the COVIDSurg cancer study. And we wanted to know more about how this collaboration resulted in so much innovation, leading to information that really changed the way things work for certain things. So Maria Popovich is a surgical training, sorry, Maria Picciochi. I'm sorry, I've got two Marias.
No problem.
There. So Maria Picciochi is a surgical trainee from Portugal. She currently is doing her PhD in the NIHR Global Surgery Unit at the Uni of Birmingham. She has been one of the steering members of the Central Committee for the COVIDSurg and the GlobalSurg Collaborative. So let's hear from Maria. Over to you.
Thank you very much, Raza, for the introduction, and thank you very much, Maria, for setting this webinar. I will start sharing my screen now to show the short presentation I have prepared, because I think the key idea of this session today is actually share experiences and try to answer all the questions that might come up after this short presentation. So not taking more time, I will start by looking at where collaborative surgical research started. That was here in the UK by the West Midlands Research Collaborative, that was funded in 2007, and it was the first trainee-led research collaborative promoting studies in surgery. Basically, the factors that supported the creation of West Midlands Research Collaborative was mainly because it was a priority for trainees to have research of high quality in their curriculum, and also because they rotate, and then it was the chance to provide and to be able to conduct multi-center studies. So this collaborative, of course, had senior support and national support, which were absolutely fundamental for its beginning, and it was led by trainees. So far, they have conducted these 3 cohort studies, and these 3 are randomized controlled trials, and they are planning to launch much more in the next couple of years. After this first trainee-led surgical research collaborative, many others followed their path, and now this is just a few examples of some of the surgical research collaboratives that are based now and that were founded after the first one. So we have GlobalSurg and COVIDSurg here, of course, but we also note that there are some collaboratives that are country-based and other collaboratives that are specialty-based. And these promote that priorities of research in different settings be prioritized by different research groups, which is really important to maintain surgical priorities and surgical research to be an answer to all the questions that there might be around the world. Starting now to introduce the NIHR Global Surgery Unit. This unit was founded in 2017 after WHO and Lancet Commission on Global Surgery have identified that 5 billion of people were lacking access to safe, affordable surgical and anesthesia care. So this Global Surgery Unit was founded with the aim to improve surgical outcomes through surgical collaborative research, and also to increase the research capacity in low and middle income countries to allow them to conduct and to lead research that were important for them. The current organization of the Global Surgery Unit, it is co-directed by Professor Dion Morton, based here at University of Birmingham, and Professor Stephen Tabiri, that is based in Ghana. And just under these two co-directors, which also shows how important it is to have a representation of high-income country and low and middle-income countries, we have, it was with a partnership between University of Birmingham and University of Edinburgh, and works with 7 established hubs so far. We have one hub in Mexico, 1 hub in Ghana, 1 hub in Nigeria, 1 in Benin, 1 in Rwanda, 1 in South Africa, and 1 in India. And to achieve those goals from where the Global Surgery Unit was founded, there was right in the beginning, there was a research about what would be important to investigate and to research in surgery that would be very important for low and middle income countries, because that is our main focus. So these 3 areas were identified as the top 3 priority in terms of research to be conducted. Access to acute care from the community, cancer care, which obviously it fits under this webinar, and perioperative care. And these are the 3 pillars that Global Surgery Unit stands for and tries to promote investigation in those 3 key areas. Then Global Surg and COVID Surg collaboratives were formed by the studies that were trying to give an answer to those 3 aims, and currently to show you some of faces of everyone who is involved. Of course, there are much more people involved that we could not have a picture from, because our network now extends for more than 20,000 surgeons and anesthetists, which is absolutely a unique place to be in terms of developing surgical research and to actually being able to promote surgical research and to promote surgical research around the world and in a global level. Explaining a bit of the background and what happens on the other side, on the organizing team, there is established about what is the role of different parts of these collaboratives. So basically, it all starts with a steering committee who develops an idea and designs the protocol for a study. And this steering committee usually has 2 or 3 co-leaders and coordinate the central team that is absolutely important to manage the whole study. Of course, the design of the study and how it will be developed, it's informed by an advisory group that usually includes some experts in the area that is being researched, and also it develops with the feedback from national leads. It's very important in the steering committee to have a strong data analysis team that will be able to provide all the statistical support that is needed for developing these kind of studies. Then the steering committee usually have a strong connection with the national leads, and the national lead is someone that is identified as an enthusiastic for collaborative research, and that will represent their country and will establish a link between the steering committee and the hospital or the local leads. They are very important in disseminating all the work, but they are also important to be this connection between these 2 groups. And also they have an important role as to provide feedback on if the study would be relevant within their country or not. Then hospital and local leads are actually one of the most hard working also from this collaborative, because they are the ones who set up the study at a local level, usually at a hospital level, try to get ethics approval or audit registration, depending on the context, and coordinate between the national leads and collaborators, all the communication that needs to happen between these two groups. Then collaborators are the ones who usually collect the data that allow us to run the study and that will allow us to perform the analysis that we need to make to reach the aims that were proposed in the first place. And then the data validator is the one who assesses the quality of the data that is being collected and that ascertains that is high quality data and it was driven and collected in the respected time and from the respected patients, and that all the ethics process was followed as well. So all of these studies, GlobalSurg and COVIDSurg, would never have happened without all these components. And each one of them, it's absolutely essential to run a study like these ones. Having a look now at the main findings of GlobalSurg 3 and COVIDSurg Cancer, and starting by the GlobalSurg 3, basically this study was based on the quality and outcomes of cancer surgery. So it looked at patients with breast, gastric, and colon cancer who were submitted to surgery across all the hospitals around the world. And initially, when in the recruiting stage, all hospitals from all countries that were providing these types of surgery were eligible to take part. From this study and the data collected from this study can be assessed in this link here. This is free of access and you can explore the data to find out what it shows, basically based on your personal interests. In this study, it was included 15,000 patients from 428 hospitals from 82 countries. And it has already 2 analyses done and studies published. One that looked at postoperative mortality and complications after these 3 types of cancer surgery, which basically showed that low and middle income countries had higher mortality and a higher complication rate after surgery, as well as patients were presenting in a more advanced stage compared with high income countries. And the second output from the analysis of this data was how hospital facilities could have an influence on cancer surgery and on cancer outcomes. So basically what was concluded was that hospitals that had more facilities were more likely to have a better cancer outcome in terms of surgical outcomes. And it seems to be an association between these 2 factors. However, more analyses are planned using this data, so bear with us to find out what we are working on now. In terms of COVIDSurg Cancer, and I was more involved in this study as being part of the steering committee for COVIDSurg, the main paper that was driven from the data collected from the cancer patients was the 3 surgical pathways that were recommended to be established during the SARS-CoV-2 pandemic. These pathways basically were what promoted safe surgery during the pandemic to the patients that could not wait for the end of the pandemic to be operated, as it is in the cancer patients. So these 3 surgical pathways are defined as a free ward, so a ward that only contains COVID-19 negative patients, a free ICU, and a free operating theater. So only these 3 together showed a difference in terms of the outcomes of developing COVID. The other study from COVIDSurg Cancer that also should be highlighted in this discussion today is the one about surgical systems. So in COVID-surg cancer, not only operated patients were included, we also included patients that were waiting to have a cancer surgery, but didn't have it yet because of the lockdowns, because of the constraints that were happening in different countries. So we evaluated what was the relation between the restrictions of that country and being on top of that hospital, and the ability and the capacity to perform surgery to these patients that cannot wait. And what this data show, and what you can see here, is that full lockdown, basically, as restrictions went up and as the income of countries went down, the number of operated patients was much lower compared to high-income countries when the restrictions were light. So overall, 1 in 7 patients did not get their planned curative cancer surgery during the lockdown, which is very worrisome. And it highlights a problem that has been here for years now, that is the fact that elective surgery and elective surgical systems are quite fragile and that are quite exposed to external pressures, and there's a need for strengthening of elective care. In terms of the impact, and focus a bit more now on COVID surge, because it was mainly the highest study conducted during the COVID-19 pandemic addressing the surgical patients. It was covered by different media nationally and internationally, and it supported many of the recommendations from WHO, Royal College of Surgeons, Association of Anesthetists, and many other colleges and associations from different countries that recommended to have something that could protect patients from COVID and that could allow the maintenance of elective surgery throughout the pandemic. We also worried about how can we get this message to the patients. So we developed these guides that were developed with a group of patients that informed what would be important to be in the guides, how it should be written, and it is now translated in more than 10 languages and available online. And what probably now are not so useful, but during the pandemic was definitely useful to inform patients of what it meant to be having surgery during those times. In terms of future perspectives, we have published more or less 3 months ago this research on elective surgical system strengthening, which basically evaluated a series of factors that are listed here and that you can see that were considered that if all those factors were in place, it was associated with an elective surgical system very strength and very resilient to external pressures. However, when these factors were not in place, it was considered that it was a less resilient system. And what you can see in this map is that the areas that have higher scores are mainly low and middle income countries. So in terms of the future, what we really want to do is to try to develop and try to implement these criteria and this surgical system preparedness index to evaluate how we can improve surgical systems around the world. In terms of next studies, we have now launched our new global cohort study, which is the HIPPO study, which will look at inguinal hernia patients, which obviously was one of the procedures that was less prioritized during the pandemic because these patients were not cancer patients, and actually the only type of surgery that was being provided in the majority of the pandemic was cancer surgery. And we are planning to do 2 trials, and CRANE is a trial evaluating a nutritional supplement to cancer patients, and probably you'll heard about some results of these soon, and you can check more information of this trial in our website. I cannot end this presentation without thanking to all the funders that supported GlobalSurg work, that were absolutely amazing and contributed to cost publications, access to increase the dissemination, and that actually have an important role when it comes to implementation and to reach the clinical side of how to decrease this gap of research and clinical. Thank you very much, and thank you especially to all our collaboratives and collaborators. We are looking forward to continue to work with you and to develop many more studies that will be relevant at a global level. Thank you very much.
Thank you so much, Maria. That was a wonderful wrap-up of how Collaborative started and then achieved so much. What do you see as the biggest challenges that any collaborative effort would encounter?
I think if we look in the beginning of establishing a collaborative, I think one of the main challenges is to have senior support and national support to actually be able to form that collaborative, because those are extremely essential to start the whole network. So let's say if a country wants to have a surgical research collaborative, probably should sought some support from previous research collaboratives and to try to know what was the process in the beginning for establishing that. Then looking at collaborative research-led studies, I think the main challenge is keeping everyone motivated and engaging them, especially with national leads and hospital leads, to increase dissemination and to increase the impact as much as possible. I think that is the main challenge.
So we have a question. Thank you, Apreya Shankar, who wanted you to expand a bit further on the Surgical Preparedness Index.
Okay, sure. Thank you for your question. So basically, the Surgery Preparedness Index was 23 indicators or 23 criteria that was considered by a focus group and by a Delphi process as being important, and that would be related to surgical resilience in terms of surgical systems. And the way that these indicators showed to be relevant was not only from this focus group, was also because they were applied in practice and really showed that had a connection between surgical system and the surgical system resilience. Also, it showed that an increase in surgical resilience would be translatable to this score. So it would be basically a feature and a skill that we could use to measure how strengthened and how resilient can a surgical system be, and to identify the main areas where it needs reinforcement. So the criteria that is included here it goes from organizational aspects, like having theaters that are only allocated to elective surgery, or having wards that are only allocated to elective surgery, but also it is related to the capacity of have electricity available, oxygen supply available, drug supply available. So it's very broad in terms of the categories that are explored in this index.
Thank you. Please feel free to type your answers either in the chat or the Q&A section. We are hoping a lot of burning questions. And while we wait for them, so both studies actually identified a lot of variation and differences between the high-income countries and lower middle-income country groups. Where do we go from these findings? How do we plan to bring or reduce this gap in the variations in outcomes?
Yeah, that's a very good question. I think that we could have a long debate about how to improve cancer surgical care around low and middle income countries, especially because it is one of the problems that is expected to exponentially increase in the next 5 to 10 years, because population is getting older. So of course, cancer rates will be higher. I think one of the important parts that needs to be addressed is surgical education and transferring of skills. That would increase the quality of surgery that is provided in these countries. But the main problem, I would say, is the access to surgery. It's really hard in these countries for patients who are in the community to recognize that they might have some signs and they need to seek healthcare. And also it is very hard after this for them to actually be able to allow them to go from their home to a hospital where surgery is provided and where there is a surgeon that actually can provide them the type of surgery they need. So there's a lot of issues in this pathway from the beginning of symptoms to the surgery that I think it needs to be improved. And basically that's all about access to care, which is not only on cancer, it's basically any disease, but of course in cancer, it's really, really worrisome. What do you think of those?
So what I could kind of get from it is that it has to be a number of interventions bundled together rather than any single intervention identified that would improve the outcomes or the variation among countries. Apreyas thanked you for this answer and thinks that the Surgery Preparedness Index will be invaluable for preparedness in Europe and LMIC and could be a good stress test for future pandemic or any health-related disaster. So that's very good.
Thank you.
Carmela, thank you for interaction. Carmela has asked a very important question, but what are the differences between the research priorities in cancer between lower middle income countries and high income countries? I mean, are there any overlapping priorities or are they starkly different from each other?
Thank you. That's a very important question. I think that at the moment, research that is being led in high income countries is very looked into the individual patient and how are we going to deliver a specific treatment and the best treatment for that specific type of cancer. So it's mainly focused on genetics, genomics, molecular level of things that can be evaluated within the cancer and drugs that could be added to the chemotherapy regimens to those patients to increase their overall survival. So it's basically a very individualized approach of the patient. Whereas in low and middle income countries, we are not there yet, unfortunately, of course. I hope we will be, and as soon as possible. But the main priority is this, that Raza was asking me about the access to care and to the right care and to also improve the quality. And one of the major constraints in these countries is they simply do not have the surgical workforce that is needed to provide the surgical procedures that are being demanded by the population. So I think these are the two opposite research priorities in these two different groups of countries. However, I think there might be an overlap in terms of priorities because I think it is the responsibility of high-income countries to help low and middle-income countries to achieve a better cancer care, because we will not be able to promote health among all ages, among all countries, without addressing this gap. So I think the overlap comes when joint forces became together from high income and low and middle income, and actually we could improve global health in general. I don't know if you want to share your experience, Raza, as well on this topic.
In terms of research priorities, I think the collaboration within lower middle income countries is not at a great level. I'm sure, but it's it's more research going in different directions and not being able to set priorities. Like that's the biggest challenge. So I think that there is a lot of room to work on, and hopefully collaboratives like this can actually try and ask the right questions that may help improve outcomes, and that's where people from low middle income countries can join in, because one of the challenges is the training and a thought process of scientific inquiry tends to be lacking in the lower middle income countries, even if we exclude the problem of resources. So this input from collaboratives actually helps improve the caliber of the questions asked by the researchers in low middle income countries. So that's how I think it will probably move forward, hopefully. Pamela has asked a very important question. Is there a financial support for collaborators per site? And I would like you to also address how the collaborative authorship model fit in, and what problems did you encounter in that?
Sure, that's a very important question, and that we actually face every time we run a new study, I think. Not only as per the costs of collaborators, but actually for the costs of ethics approval, for instance. Whereas in high-income countries, it's quite rare to find a country where we need to pay for developed research and for research to be approved. In many low and middle-income countries, there's a fee associated with the ethics approval process, which can be a barrier, of course, of improving research in these countries. Considering the collaborators and financial support, we usually do not have funds to support it. Usually we identify collaborators that are enthusiastic and motivated to collaborate with us with data collecting, and because the output usually it's not about the money, it's more about what they will gain and what are the skills that they will gain from the experience that will allow them to grow in the future. So basically, as a data collector, you will gain skills in terms of how to collect data from a patient, how to collect data from clinical notes, how to read the protocol. What is important here is this data related to what they are trying to answer. So I think those are important skills if you want to develop research in the future that you would gain by joining these type of studies. And the authorship is definitely another benefit from all of these collaborative studies. So everyone collaborating in these studies is recognized in the authorship. And probably you've noticed from the titles that I screenshot in the presentation, there's only one line for the authors, which is the name of the collaborative, because the work developed is so important amongst the different categories of the team that would be unfair to put just the name of 10 people in that area. So the principle is always use the name of collaborative, and then in the appendix, everyone is recognized by their work and everyone is PubMed citable authors of all the papers that are produced from the data that were collected and contributed by them. So I think that's another benefit of joining these studies, that it goes, I understand that the money can be a barrier, but I think the advantages of joining these types of study are more than the money itself, let's say like that.
Thank you so much. I think COVID surge especially changed the way collaborative authorships are looked at, because the concept was still there, but then you would say, okay, yes, I contribute, and it's more like trophy authorship or something that's just there. But then with the COVID surge studies and the collaborative just churning up one after the other papers, and they started getting cited, and people actually started looking at their citation indices, which creeped up quite steeply. It just, I think for the subsequent studies, it improved the resistance that or hesitance that people had in joining such a collaborative. People were actually asking, when is the next study I want to join? So that's, I think that the collaborative itself changed the way collaborative studies are looked at, and that's a great achievement. Amit Gupta has asked, thank you for this question. Is there any randomized trial pipeline in these collaborative studies?
Yes, we are preparing them. However, I cannot share the information yet, sorry. But yeah, we are preparing a next randomized control trial. So you'll be here soon by what we are preparing. And just highlighting on the topic that you just said, Raza, about the dissemination and the impact and citations of the work. I think that's also because of all the work that was developed through national leads, through hospital leads, and to data collectors. Because I think implementation of these findings into practice only makes sense and only is facilitated if everyone puts an effort to disseminate the findings. So one of the strategies that we developed in COVID surge was to disseminate a couple of slides showing the main areas and the main messages that we researched and that were available to all national leads and hospital leads to disseminate the findings in their local settings. And I think that when your hospital sees that the work that they approved months ago actually had that output, and actually it's influencing all of those recommendations and guidelines, they probably will easily accept another study from a collaborative research. So I think dissemination is very important, and it is also led by the national leads and hospital leads. It is definitely not a work done only by the steering committee.
Also, I think one of the advantages that at least I experienced was the kind of networking that you got in participating in such a global collaborative. Networking within the country, as I was fortunate to be one of the national leads with my other lead, Professor Azhar Qureshi. And it helped me get to know so many brilliant people within my own country that I wasn't, I didn't know them. And also the way the groups were organized. So they were organized according to regions. So you'd know people within your region, and they were organized according to disease type. Like, for example, there were groups for sarcoma, groups for colorectal cancers, breast cancers. And that really boosted the network of people that you can connect to and reach out to. And then again, being part of the same collaborative actually breaks this barrier, and you can actually go and contact people for your queries, for example, and that really helped. I think that's a great achievement of this collaborative.
Yeah, it's great to hear that feedback, and I think that probably as a national lead, all the contacts that you developed as a national lead will help you to use, particularly in the future, if you want to develop a study that you want to run in your country, because it's a high top priority of research in your country. You can definitely use those contacts to do it. So I think collaboratives have that advantage as well. It allows people to connect that probably would never be connected if there wasn't these types of studies. So I think that's really important as well. Oh, I think you're muted, sorry.
Yeah, sorry. Dr. Walid Fahmy has asked how to be a hospital lead for GlobalSurg.
So we usually have the hospital leads and national leads are established according to the study. So for instance, you don't need to be a hospital lead in previous studies to be a hospital lead now. Usually, because we have this process running all over again with each study, usually each study has their own organization of how to become a hospital lead. Usually it is widely disseminated in social media, especially Twitter and Facebook, when a study is launched. And then usually it's to fill a survey or to contact a national lead that was identified already to become a hospital lead. So at the moment, the study that we are running will not be cancer focused, but the way that we are registering hospitals interested in taking part is through a link that it's basically just fill a survey, and then we contact you to know more information. And if there was no one from your hospital that was identified, we confirmed you as hospital lead and put you in connection with a national lead from your country if it was already identified. So I think that if you want to become a hospital lead, I think you just need to keep an eye on what are the studies that we are launching and to fill the survey. Usually it's through a survey that we ask that.
Thank you very much. If there are no other questions, we'll just probably like to conclude with what would be your, if you would want to say, being part of this amazing group of people and a huge network globally, what is your biggest or the highest takeaway from this, if you want to have one thing
from the collaborative or from this webinar?
From the collaborative.
I think so. When I joined GlobalSurg, I was still a surgical trainee in Portugal, and then I moved here to Birmingham to do the PhD and to be more involved in this. I think, like, if I only have to choose one thing, is to be able to have a role or to at least know that I contribute in some way to surgical patients and to better surgical outcomes. Because I think that as a surgeon, and I'm talking, but I only completed 1 year of training so far. So I'll go back to it after I finish the PhD. But in my head, as a surgeon, the amount of work that you can do to actually help your patient is quite limited because you're only one person. You can only operate one patient at a time. So you will only be able to provide surgery to a certain constrained population, let's say. And when you think about it, and when you think about why did you want to become a surgeon, that was obviously to save them from the surgical disease as much as possible. Of course, you want to have a higher impact. And I think the way to have a higher impact and to feel that you actually saved more lives is through collaborative research. I think that is the main message from these GlobalSurg and GlobalSurg work, and I'm very excited to be joining this team now, and I'm looking forward to be involved in future projects as well.
That's amazing. That's really a great takeaway from the whole effort and this amazing group of people. Each one of you is really very helpful and supportive, and it's always great to connect with any of you outside the collaborative or for the collaborative. So thank you so much. I thank all of the participants for attending this webinar. Thank you so much, Maria, for representing the collaborative and telling us all about how it all started and how these studies took shape and finally what they produced. This was a great achievement. And I will pass over to Maria Popovich to make any announcements before we close.
Yeah, let me just thank you everyone for all your questions. And thank you, Raza, for joining me in this discussion. I hope it was useful for everyone. And it was really nice to finally have a chat with you on one-to-one to discuss about the challenges of collaborative research. Thank you very much, all.
Thank you, everyone. Thank you to the panelists and thank you to participants. I will just let you know that this was the first webinar of the series of Innovation Through Collaboration. You can find the rest on our website under courses.